Third degree heart block, also known as complete heart block. We're going to define third degree heart block. We're going to list the diagnostic criteria for third degree heart block. And we're going to identify third degree AV block by utilizing the rules of ECG interpretation. So with a third degree or complete AV block, there is absolutely no communication between the atria and the ventricles. At the AV node/AV junction, there has been a complete blockade between the conduction as it goes from the atria to the ventricles. There will be two pacemakers in this situation. You've got a supraventricular pacemaker that's trying to deliver a conduction to the ventricles, but then you have a ventricular pacemaker because the ventricles are not receiving that impulse, and so they have to take over and start creating a pacemaker. Atrial and ventricular rates are typically very different in this because atrial rates are going to be much higher. You won't have any type of capture or fusion waves anywhere. The key features at PR intervals are completely changing and have no effect on the ventricular rate. And in reality, there is no PR interval because the P wave is doing its own thing and the QRS is doing its own thing. The third degree AV block is the most serious type of heart block, and it may progress to a systole because the ventricular rate is usually very slow and ineffective. It's a complete heart block and is also referred to as a lethal dysrhythmia. Also termed AV dissociation because the atria and the ventricles beat independently. There's technically no PRI, as I've mentioned, and some P waves may be buried in the QRS complex and not visible on the EKG strip. And that's going to be important that we remember that because the P to P is regular, and as we're going to see in some examples in the future, those P waves may be buried, but we're still going to have to count them for the atrial rate. The pattern illustrates regularly occurring P waves and QRS complexes, however, no relationship is noted. So, all communication shut down between the atria and the ventricles. If the AV node is pathologically turned off, a complete block is created at the interventricular septum. The atria and the ventricles are completely oblivious to each other, and impulses are generated by two separate pacemakers. One supraventricular pacemaker and one ventricular pacemaker. Each pacemaker will keep its own intrinsic rate and control its own respective set of chambers. The atrial and ventricular rates will each be different since they are firing at their own intrinsic firing rate. In third degree AV block, the supraventricular pacemaker, since it is a higher order pacemaker, will usually fire spontaneously. A ventricular pacemaker will also be mandatory in order to maintain cardiac output and hence life, but it's a lower order pacemaker from the ventricles, and it must fire and set the ventricular pace in order for the patient to survive. The morphology of the rhythm will depend on the two individual rhythms that make it up. The two individual rhythms depend on the ectopic site of the pacemakers involved. If the supraventricular rhythm originates in the sinus node, the morphology of the complexes will be sinus in nature. If they originate in an ectopic site, the morphologic appearances of the supraventricular rhythm will depend on the location of the ectopic focus that created it and the route taken by the atrial depolarization wave. The morphologic appearance of the ventricular rhythm depends on the site of the ectopic foci that created it and the route of transmission that the ventricular depolarization wave takes through the ventricular myocardium. An ectopic focus that uses only direct cell-to-cell transmission will give rise to a very wide QRS complex. And an ectopic focus that uses any part of the electrical conduction system will be narrower, reflecting the faster rate of transmission of the depolarization wave. These are two examples. This first example, you've got a pacemaker that picked up in the AV junction, so it's got a narrow QRS. In the second one, you've got a QRS that's wide, which indicates the pacemaker picked up in a ventricular focus, a lower focus. The P-to-P intervals across the board are the same, if you notice, as demonstrated here with the little graph, but the supraventricular, so the P waves and the ventricular waves, will have no association. Even if you happen to see what you think is a PRI, it's just because it happened that way. It's not a PRI that is part of the strip. The atrial rate's usually 60 to 100, but the ventricular rate's going to be based on the side of the escape pacemaker. You're going to have two rates, your atrial rate and your ventricular rate. Atrial rhythm is regular, the ventricular rhythm is regular, but they're not regular together. There's no relationship to QRS complexes, and there is no pattern of PRI. There is no PRI. The QRSs will look alike, but again, it's going to be based off of the site of the pacemaker. So here's an example of a third-degree AV block. Now remember, as I mentioned earlier, because you've got a regular P to P interval, you know that there would be another P that fell right in here, and so we've got to make sure that we count that P wave. So your atrial rate is around 80 and your ventricular rate is 30. But there is no pattern with the PRI. Same thing here. We notice a wide complex QRS, but then we notice a regular P to P interval, but don't forget that you've got hidden P waves. This one is more of a narrow, indicating that it is a junctional ectopic area that started the pacing for the ventricles. And you've got a P to P, you've got a hidden P wave right there. So the signs and symptoms exhibited by the patient may be indicative of severe hypoperfusion. If the QRS complexes are narrow and the patient is asymptomatic, the AV junction is most likely serving as a pacemaker site. If symptomatic, drug therapy or most likely pacing may be indicated. If the patient's exhibiting signs and symptoms and the QRS complexes are wide, transcutaneous pacing followed by the insertion of a transvenous pacemaker in the hospital will most likely be indicated.